So buongiorno, welcome everyone. Thank you for joining us this morning. The title of today's symposium is Micropulse Continuous Wave Laser Therapy for Glaucoma and Retinal Disorders. These are my disclosures. I'm Tomas Grippo from Argentina. And the objective is to review different laser treatment options that can help us cover the heterogeneous glaucoma clinical spectrum that we encounter in our daily practice, as well as the use of micropulse technology in retina. We will be covering three different techniques. One is the micropulse laser trabeculoplasty, or MLT. The second one is micropulse transscleral laser therapy, or micropulse TLT. And the third one is traditional transscleral cyclophotocoagulation. Today, we have Stela Vujosevic, who's a retina specialist, who also has a lot of experience with glaucoma patients. She's a researcher at the University of Milan and head of Retina at San Giuseppe here in Milan. And we also have Raffaele Turano, who's an anterior segment surgeon and the head of the glaucoma unit at the University of Brescia. Stella is going to be talking about micropulse laser trabeculoplasty, and Dr. Turano will be talking about transscleral CPC. Stella?
Thank you, Thomas. It's my great pleasure to be here with you today. We will start with the talking of the use of the micropulse in retinal disease and then also in glaucoma for the laser trabeculoplasty. And the reason why we start from the retina is because everything started from there, I would say. And the experience in the use of the micropulse laser in retinal diseases is already, I would say, really significant and all around the world. So these are my financial disclosures. So the micropulse laser treatment is a revolution and represents the revolution in a retinal laser technique treatment because it has shown to be safe and effective treatment that does not damage the retina, but it restores its normal function. However, the lack of standardization in the use of specific parameters has limited its use in clinical practice. So when we think about the laser treatment in retinal diseases, we have started from the conventional so-called ESCRS treatment, where we had all these burns in the retina. I think we are all familiar with these images. And then the evolution led to development of the modified ESCRS treatment, where the laser spots could have been seen on fluorescein angiography or autofluorescence. And finally, we have the micropulse subthreshold laser treatment, where we don't see any changes on the fundus. In the sense, we don't see any scars on fundus autofluorescence or also on OCT. And if you look at these images that are the microperimetry, so the sensitivity of the retina after the treatment, the subthreshold micropulse laser can improve retinal sensitivity, and it has been shown in a prospective trial, whereas standard laser decreases retinal sensitivity as it creates the scotomas on the retina. So what is the micropulse laser treatment? What does it mean? It means that when you perform the treatment, so during your duration of the laser beam, you have this chopping of the pulse duration in a very, I would say, short pulses. So the shorter duration is, the safer treatment is. And in this way, there is no significant elevation in the temperature in the retinal tissue between the laser spots. So in this way, there is a minimal diffusion of heat in the retinal tissue, as the temperature elevation is only during the on phase of the laser treatment. you have different duty cycles that you can use when you perform the micropulse laser. And let's say that for the retinal treatment, the safest one and the one most commonly used is 5% duty cycle, so it is the shortest duty cycle, whereas for the MLT treatment, you use the 15% duty cycle. So the therapeutic mechanism of the micropulse laser in the retina is the object, I would say, of debate, how it acts on the retina. So firstly, it was considered that it acts only on the retinal pigment epithelium cells, that it improves its function. But thereafter, some studies in vivo performed in the aqueous humor of the eyes of the patients, for example, with diabetic macular edema, has shown that it reduces the inflammatory response in the aqueous humor and then in the retina by the reduction of different cytokines that are produced by the retinal glial cells, such as, for example, the Muller cells or the microglial cells. And it has been also confirmed by the studies using the OCT, where a major decrease in retinal thickness has been found in the inner nuclear layer of the retina, and that is the layer where the bodies of the Muller cells are located. Also, some experimental studies that have been recently published in Japanese Journal of Ophthalmology show that there is a difference in gene expression between the continuous wavelength laser and the micropulse laser, in the sense that the continuous wavelength laser, or standard laser, is prevalently involved in the upregulation of the genes that are related to apoptosis, whereas the micropulse laser is prevalently related to the genes that are involved in the photoreceptor cell maintenance and development. So these differences can also help in the explanation of the different molecular mechanisms of laser-induced thermal effects. So what has been, let's say, debated and we tried in the retina world to standardize is that when you perform the micropulse laser, you need to perform the low-intensity treatment, but a high-density treatment. So it means that you need to perform, to deliver a lot of spots where it is in the retina or in the trabecular meshwork, and these need to be at a low intensity. You don't need to titrate it, so you can use always the standardized parameters. You can see here that, for example, in the, when you want to perform the confluent treatment, it is easier if you have this TXL program, let's say, because you have the grids that are already available, and you can perform it in a standardized manner. It can be, 7x7 grids, 2x2 grids, or whatever, and it has different shapes. You can see, or it can be a circle, or it can be the arcus, or it can be rectangular. We found in the retina world, so we found in the sense of the retina specialists, that the fixed parameters are more secure than titration, and that is something really important to know, because it is different than when you use the continuous wavelength laser, where you are used to see the laser spot on the tissue that you are treating. Here, you don't need to do that. And these are the parameters that we use with the 577 nanometer laser, or this is the infrared laser. And you see that for the retina, we use always the 5% duty cycle, the 100 micron spot, and the power is always the same, 250 milliwatt for the retinal diseases. The micropulse laser improves retinal function, and it has been shown with different techniques, so with visual acuity, with mesopic visual function, so it is the microperimetry, visual field, and also retinal electrophysiology. And the current indications for the retinal diseases are definitely the mild diabetic macular edema, central serous chorioretinopathy, and macular edema due to retinal vein occlusion. These are the indications most frequently used and with the longest history. So let me just show you. This is the case with the macular edema before subthreshold micropulse laser, and this is after the subthreshold micropulse laser. This is a specific type of autofluorescence, color autofluorescence. You don't see any changes on the retinal pigment epithelium after the laser treatment, and also no CT, you don't see, let's say, any changes at the level of the outer retina in the sense of the damage on the outer retina, but you see the decrease in retinal cysts. And this, I would say, the safety of the laser and the efficacy have been studied in different studies by different groups. And recently also we have evaluated the changes on OCT angiography after the subthreshold micropulse laser. We have seen that there is a significant decrease of the microaneurysms in the retina, even if the microaneurysms are not the specific target of this treatment. So we don't burn the microaneurysms, it's not the objective, but we treat all the macular area, and then you have it as the secondary effect, the decrease of the number of the microaneurysms. When compared to the standard laser, this meta-analysis of randomized clinical trials with a duration of 1 year showed that the better functional results are obtained after the micropulse laser when compared to the standard laser, and the anatomic results are comparable. And just recently, you see this is still ahead of print, published in Ophthalmology. This is a big prospective randomized trial performed in the UK in 16 different centers, where the standard laser has been compared to the micropulse laser in diabetic macular edema with central retinal thickness less than 400 microns. Because these are the cases where, for example, the NICE does not recommend any treatment. So they saw that there is no significant difference in in the primary outcome, that was the change in best corrected visual acuity after 2 years of treatment, and there was no difference between these two treatment groups also in all the other secondary outcomes. And the major part of the patients, more than 95% of patients, had the driving license even after 2 years of treatment. So as the micropulse laser was equivalent to the standard laser for the treatment of this initial macular edema, and it is a cheap and effective treatment, the conclusion of this important study was that the micropulse laser should be offered to people with diabetic macular edema and central retinal thickness less than 400 microns. Here you can see a case of macular edema due to branch retinal vein occlusion. And this patient, you see, had this, I would say, relatively good visual acuity with central cysts and neuroepithelial detachment. The patient was treated with 3 aflibercept injections and 2 micropulse laser treatment in a year time. And you see that the vision is now 85 letter CTDRS score, so it is 20/20. The edema is almost completely reabsorbed, and we managed to manage this patient with only 3 injections in a year time, that otherwise the patient would need many, many more injections. The first indications that I showed you, the most used one, are not the only one where you can perform the micropulse laser. There are also all different types of maculopathies where you can use micropulse laser, and there are also some literature on all of these cases that I showed to you. So it is definitely the treatment that you can use in different occasions. But not only for the retina. The Micropulse laser can be used also as the trabeculoplasty for glaucoma. Why? Because it addresses concerns of compliance with medical therapy, and it has advantages over medications, that it reduces patient cost and there are no side effects. You can see here the different wavelengths that, for example, the Iridex has, and also because it is a repeatable treatment, and also due its portability, multifunctionality, because with the same laser you can perform both the retinal and also glaucoma treatment, and also because it is less expensive than SLT. So what are, let's say, some of the data that are available on the use of the MLT? The IOP reduction varies between, you can see, 12 and 21% from the baseline IOP values. The effects are comparable to SLT, obviously. When you compare the results, you should compare it to the laser treatment, not to the meds. It is also considered, let's say, safer because of no induced inflammation or no induced tissue changes, and there are also no significant IOP spikes after the treatment. The mechanism, the therapeutic mechanism is still not completely understood, definitely, but what is known that there is no lethal cellular damage from cumulative thermal rise or scarring or morphological changes in the trabecular meshwork tissue, and that there is no post-operative inflammation. So several mechanisms have been postulated as the therapeutic mechanism of the MLT. So one was the mechanical pooling open of the uvascular trabecular meshwork and Schlemm's canal, or the cellular mechanism that stimulates cell division, or the third one that is very similar to the one that we have in retina, and it is the stimulation of a cellular biochemical cascade via cytokine release to increase aqueous outflow while reducing tissue damage, as it was shown, for example, for the retinal treatment in the aqueous humor. So if you compare the micropulse laser trabeculoplasty to the selective laser trabeculoplasty, you can see here all the, let's say, similarities and also all the differences between the two treatments. Definitely what I would like to point is that, for example, the inflammation is not observable after the micropulse laser, where you can find it after the SLT. Also, the spot size is different. It is 300 micron after the micropulse laser and 400 after the SLT, and that there are no, I would say, no or minimal complications after the MLT, whereas, for example, after SLT, you can find the IOP spikes. The available literature on the use of the MLT shows, I would say, variable results on the IOP change, but it is obviously also due to the use of different lasers, of different wavelengths to perform the treatment. So you can see 810 nanometers, 577, which is the yellow, and 532 nanometers, the green one. But you can see the change varies from 12 to almost 20% usually after the treatment. And the studies that compared the MLT and the SLT show similar results in the IOP reduction. You can see that these are very comparable results. So how to perform the MLT treatment? So you can have this standardized setting with using the 577 nanometers laser, so 300 micron spot size, 15% duty cycle, okay, 300 millisecond duration. The power is set at 1000 milliwatt power, and you treat all 360 degrees with at least 200 spots. So you don't need to be afraid to do, let's say, all of these spots, because otherwise it is really the under-treatment of the patient, and you can easily retreat the same area. You can use the 3-mirror Goldman lens or the MLT also lens. Just to show you, these are some initial data, because this is our ongoing clinical study on 43 eyes on ocular hypertension, eyes treated with MLT versus 27 eyes that are ocular hypertension controls. The follow-up is in course, so it will be 12 months study. We are performing all different evaluations of the patients, OCT, OCTA, visual fields, microperimetry, and the measurements of IOP, just to show you that the groups were very similar at the baseline. There were no significant difference. And just to show you some initial data, so these are the changes in the IOP at different time points, and it has been always significant, the difference between the MLT-treated eyes and the controls. And for the time being, we found that the best reduction was at 6 months, and it was 18.4% from the baseline in IOP. These are just the data on OCT, retinal nerve fiber layer, that there were no changes and no differences during the follow-up between the two treatment groups, and also retinal sensitivity during the follow-up remained unchanged. There were no scotomas and no differences between the treatment and not treatment, and also as OCT parameters, the vessel density in the superficial capillary plexus and also in the radial peripapillary capillary plexus. So just to conclude, MLT can be a viable treatment option, specifically in the initial stages of the disease, for example, in the ocular hypertension, high-risk eyes, but also it can be an add-on or replacement treatment, for example, for the reason of efficacy of the treatment, tolerability, and adherence. You can see all the cases where you can use the laser treatment. Obviously, you need to have a good angle, I would say, so the closed angles are not good, definitely not good candidates. And you can see also what are the contraindications of the treatment. And thank you very much. With this, I have finished.
So now I'm going to be talking about Micropulse TLT. And the first question is, what is Micropulse TLT? It's a versatile, non-incisional procedure for the treatment of glaucoma that is performed with the Iridex Cyclo G6 laser and the Micropulse P3 delivery device. So what are the main, most of us are familiar with traditional CPC. And the second question that arises usually is, what are the main differences between both technologies? When it comes to Micropulse technology, as Stella was mentioning, what it does, it splits the laser beam into off and on periods. And this causes changes on the amount of energy that actually gets delivered to the tissues. And usually with Micropulse TLT, you get lower temperature targets and a greater thermal control of the treatment that you are actually doing. And this contributes to a lower risk of complications. And therefore, Micropulse TLT is usually indicated in a broader spectrum of patients. Then, when you place the probe with a traditional CPC, you're aiming actually more anteriorly. With the Micropulse TLT, you're treating more at the level of the pars plana versus the pars plicata with a traditional CPC. And when it comes to the technique with traditional CPC, what we do is we usually do discrete spots. We place the probe on top of the eye, we do a spot of treatment. With Micropulse TLT, what we do is a continuous sweeping motion on the eye, as you will see on this video here. So this is a typical treatment with the Micropulse TLT. This is one of my patients. You can see that I'm actually treating the upper hemisphere here. Usually we treat the entire eye, so the upper hemisphere and the lower hemisphere, and we skip the 3 and 9 clock hours.
Bien.
And what are the proposed mechanisms of action? You know, while the mechanism of action is not fully understood, it's theorized that Micropulse TLT enhances both the conventional and the non-conventional outflow system, as opposed to restricting only the ichthyomer production. So one of the mechanisms, it's a pilocarpine-like effect, where the muscle fibers are actually contracted, pulling the scleral spur posteriorly and widening up the trabecular meshwork and Schlemm's canal, therefore facilitating the conventional outflow system. And a second mechanism is a prostaglandin-like effect, where there is inflammation and scarring that facilitates ichthyomer through the non-conventional outflow system. And this technology was first applied in glaucoma back in 2015. Actually, the first clinical study was published by Aquino and collaborators in Asia. And what they did is a prospective study with about 50 patients, where they randomized and compared traditional CPC, which was the standard in patients with refractive glaucoma, and Micropulse TLT. And what they found after 18 months of follow-up was that with the Micropulse TLT, there were less side effects, so it was actually safer, and you also had more effective results over time. Since then, until now, there are probably like 60 or 70 peer-reviewed publications. And when you look at it all together and you want to see what the outcomes are, most articles in the literature say that Micropulse TLT is safe and effective. Always keep in mind that this is a glaucoma procedure, right? Then the intraocular pressure reduction ranges between 30 and 50% with the original probe. And most of the literature was done with the original probe. Now there is a revised probe that I'll be mentioning a little bit later on, but that initial literature showed a 30 to 50% pressure reduction at 12 months with stopping PO glaucoma medicines, acetazolamide, right? Since this new revised probe showed up in the market, there has been one series, this was recently, right? There was one series that was presented at AGS early this year, where they saw a 44% reduction at 12 months in patients with glaucoma. And I will be mentioning about a consensus effort that we did throughout the last year, where a panel of glaucoma specialists with significant experience using Micropulse TLT gathered together and did a review of the literature and came up with guidelines. And also came up with settings, starting settings for Micropulse TLT. And the expected outcome is to decrease pressure between 25 to 35% with those starting settings that I'll be explaining a little bit later on too. So when do we start considering Micropulse TLT within the glaucoma spectrum, of our patients? In general, it becomes a surgical option once, the medical therapy and laser trabeculoplasty have actually failed to control the disease. So after that, we can consider Micropulse TLT as one of our surgical options. And it's most typically used in patients with poor IOP control who are not good candidates for or who do not wish to undergo incisional glaucoma surgery. It's also used prior to incisional surgeries. It's also used in patients who've actually failed incisional surgery, so after incisional surgeries. And if you have patients who are on stable but on maximal tolerated medical therapy, including, for example, PO medicines, it's a good indication to do this procedure in those patients, right, to decrease the amount of medicines that they're actually taking. The indication is very broad. It goes in patients with moderate glaucoma to severe glaucoma, could be open angle, closed angle, or secondary glaucomas too. You can do it in patients with prior incisional surgery and also on maximum tolerated medicines. If you're just starting to do this, I mean, if you're not familiar with Micropulse TLT and you want to start using it and you want to be conservative at the very beginning, you should start considering it if mixed procedures, trabeculectomy, or tube shunts have actually failed on your patients, and then do it. Once you start becoming familiar with it, then you can just start to broaden up the indication. My personal journey with Micropulse TLT goes back to 2016. I've been doing research since then, and I can say that there are two major events in the recent evolution of this technology. As I was mentioning, one of them was the development of the revised probe, and the second was the consensus effort. So the revised probe, here you can see a picture of it, it has a more intuitive orientation because it has those little like bunny ears that go towards the limbus. That's where you actually place the probe. Then it allows for more consistent application of the energy because it has this scleral matching curvature. So as long as you keep the probe pressed against the eye, the energy is going to be heading to the right direction. And because it has a smaller foot plate, it enhances visibility, which makes the technique easier. And this is the presentation, the AGS presentation from Dr. Checo and collaborators that I was mentioning to you, where they used this revised probe. What they did is they prospectively evaluated for like 12 months 2 groups of patients with different total treatment times. So one group had like 50 seconds per hemisphere. The other one had like 60 seconds per hemisphere of treatment with 2.5 watts and setup duty cycle. And they were able to decrease the pressure from like 29 to 17 in one group, and from 25 to 14 in the second group. The mean number of medications was reduced, but it was not significant. And just with solo treatment, so just with one application, 100% of their patients achieved an IUP reduction that was greater or equal to 20%, and 73% of those patients reached a final IUP that was less than 21. There were no complications observed, and about 15% of patients required reintervention after the follow-up period. And this is the consensus panel. It was about 10 glaucoma specialists from Europe, from the United States, and from South America. And the objective was to provide a peer-driven contemporary clinical guidance on the use of Micropulse TLT for glaucoma. So if you really are interested in this technology, you can just get this, these publications that are like available online in PubMed, where everything about Micropulse TLT up to today is being reviewed. This paper that you see on the right lower side was the first publication, and it was mainly focused on dosimetry, so what are the appropriate settings, and patient selection. And we just submitted another one where we review the surgical technique, post-op care, which I'll be mentioning now during this presentation. So I will just describe a selection of those consensus findings. And one important concept to understand is that there is a sweet spot that balances efficacy, so the pressure reduction that you get, with a safety profile. If you're just too gentle, too soft when it comes to the parameters that you use, it's going to be very, very safe. You will have no side effects at all, but the effect, you will have a pressure reduction which may not be so significant or may not last long enough. Now, if you're very aggressive, I mean, you will certainly decrease the pressure, but you may have some side effects. So there is the sweet spot that really balances safety and efficacy. And for the original probe, this sweet spot is an amount of total energy between 150 to 200 joules. And I'll translate this a little bit later on. And one of the things we also realized that that even with the, our consensus settings, I mean, we may be under-treating a little bit. I mean, we may be a little bit gentle, and the upper range of treatment is still yet to be defined. Another very important concept, if you look at the literature at the very beginning, really nobody was paying attention on how fast you would actually do your sweeps, because we were all used to traditional CPC, where sweeping that didn't exist, right? And this is, it's about like putting your finger on top of a candle, right? If you go just too fast with your sweeps, you probably won't feel the heat. If you go too slow, you will burn yourself. But if you actually go in a moderate like speed, you will actually feel the heat. And the same happens with the sweeping with the Micropulse TLT. If you go too fast, you may not be delivering enough energy to the structures that you're trying to treat. If you go too slow, energy may be building up too much and maybe causing some side effects. So you want to find the right sweep velocity, which per the consensus is about 20 seconds per sweep. And this is just a graph showing that if you go slower, the temperature actually will go higher and it will last longer than if you go very slow. So at the very beginning, most of the articles, the sweep velocity was about 10 seconds. Nowadays, I mean, we go much, much slower, and we pay more attention to that. Then you have to keep in mind that the maximal IUP lowering effect you will see within 4 to 6 weeks of the treatment, though during the first week, you will see already a tendency. Micropulse TLT is a titratable procedure that can be repeated without limiting the possibility of doing other glaucoma procedures later on if needed. There is no need for cycloplegic or antibiotics. It's a non-incisional procedure. It doesn't cause significant inflammation. Usually after treatment, you will just use topical steroids for a couple of weeks or some NSAIDs. And the glaucoma, usually PO glaucoma medicines are stopped right away. But the topical glaucoma medicines, you will start to taper as the response starts to build up. And the post-op care is really very, very less demanding than the traditional glaucoma surgeries that we're used to. When it comes to the technique, it's very important to use a coupling agent between the probe and the eye that has to be viscous, transparent, optically neutral, such as lidocaine gel. It's important to place the bunny ears, that part of the probe on top of the limbus. And if for some reason you cannot define the limbus very well, you may aim a little bit more, you may error a little bit more posterior. And it's important to make sure that the entire footplate is flush against the sclera, the conjunctiva, and that you avoid the 3 and 9 o'clock hours because of the vasculature and the nerves that actually go there. When it comes to what are the starting treatment parameters, it's this ones. 2.5 watts of power, a duty cycle that's always set up at 31.3%, and then 4 sweeps of 20 seconds, like I showed you on the video, per hemisphere. If you have a patient who has very high baseline pressure, needs a low target pressure, or has advanced disease, you may consider increasing the amount of energy that you're delivering 20 to 25%. That means going, for example, from 4 sweeps to 5 sweeps per hemisphere. Some doctors may decide to do, instead of 20 seconds per sweep, may do actually 30 seconds per sweep. But don't change all the variables at the same time, otherwise you will not know exactly how much energy you're delivering to the eye. And now, as a conclusion, I found, and the panel of the consensus found, that Micropulse TLT is a very useful addition to your glaucoma armamentarium. With proper surgical technique, like we described, at energy settings within the boundaries that we recommended, Micropulse TLT is a safe and effective treatment options for many types and stages of glaucoma. Design improvements like this new probe and laser delivery have actually enhanced the procedure and made it easier and more user-friendly, so it's easier to perform the procedure. I mean, the learning curve is very short. And the consensus effort, and let me reinforce that, if you are interested in this technology, try to see if you can find those papers online. The consensus effort has allowed for standardization of the treatment and more consistency in general. And it's a technique we have to keep in mind, like everything in glaucoma, it's a technique that is actually evolving, and future research and experience will allow us for continuous improvement of this technology and how we use it in our field. So this is it for my lecture. Now I'm going to invite Raffaele to actually talk about traditional CPC.
Okay, thank you, Thomas, and thank you to Iridex. We will speak about the continuous wave transscleral cyclophotocoagulation. What are our target? The target is the ciliary body that is composed of about 80 ciliary processes, and the target of the laser is and the target of the laser is this layer of pigmented epithelium. Here you can see after the treatment is this is on the left. Here you can see the effect of the laser on the ciliary processes. You can see a blanching and a shrinking of the processes, and this is a coagulation, different from the micropulse treatment. What about the probe? This is the probe, this is the laser machine, the laser box. You have to put the probe on the position the probe on the limbus. The edge of the probe matches perfectly with the convexity of the sclerocorneal limbus, and the laser beam is positioned at about 1.2 millimeters behind the limbus. You have to treat 3 quadrants with about 7 or 8 spots per quadrant, and you need to avoid the 3 and 9 o'clock meridians to avoid an ischemic anterior ocular syndrome or atonic pupils, treating the posterior long ciliary artery or the ciliary nerves. The ciliary processes are located approximately at 1.5 millimeters from the limbus, but not ever. Here, there are some cases in which the location of the ciliary body can vary among the same quadrants of the eye, among different quadrants, and between patients with different types of glaucoma. In this study, the distance from the limbus to the anterior margin of the ciliary body is assessed by scleral transillumination. And as you can see, for example, in the superior quadrant, there is a big variability from the distance to the limbus, from 2 to 5 millimeters, and also in the different quadrants of the eye, there is a variability. So when we have this challenging patient case, when you need to treat a particular condition like congenital glaucoma with abnormal ocular size, or when the corneoscleral limbus is difficult to visualize, or when we treat IG myopic eyes or post-corneal transplant patients, the ciliary body can be located more posterior. So we propose and we use a new approach. This is the illuminated probe. Using the transillumination, is possible to see the right position of the ciliary body that is not in the same position of the limbus, but is more behind the limbus. With this probe, you can see the right position, and you can mark with the marking pen, and so you can treat your target very well. Here you can see an example. Remember that you don't have to treat and don't have to, to position the probe on the marked point to avoid the burn on the sclera or conjunctival tissue. This is the standard indication of the continuous wave, for the continuous wave transscleral CPC, the management of refractory glaucoma. Remember, with with poor vision or limited visual potential, the type of glaucoma are these classic neovascular, traumatic, aphakic, after silicone oil, after a vitrectomy, after a uveitis, and congenital or development glaucoma. And this technique is used also to give a relief for in a blind, painful eye. There are two techniques that you can use. This was proposed by Dr. Gasterland in 1992, and is called standard pop titrate setting. You have this starting power, and then laser energy is increased in steps of 250 milliwatts until you hear a pop. A pop indicates the coagulation of the tissue and the boiling point of the water in the choroid. Whenever you hear a pop, you have to titrate upward the power and in the measure of the 250 milliwatts. But there is a new technique that is proposed by Dr. Gasterland, but is newer, the so-called slow coagulation or slow burn technique. You have as you can see, the power is lower and the duration is longer, and is different this technique from to treat the dark or light brown iris, and you have to put up to augment the power if you have a lighter color of the iris. We recommend the use of an interface when you do the procedures, like a gel or viscoelastic based on methyl cellulose to protect the sclera and the conjunctiva for the burns. This is the classical complication, but if you look at the most site-threatening complication, like hypotony, in this paper you can see that there is a comparison of the slow coagulation and standard coagulation techniques. You can see that hypotony has a very low manifestation, from 0 to 4%. But the most important thing is that in the slow coagulation group, you have very few inflammation, 34% versus 74% of inflammation in the standard pop treated group. And no eyes in the slow coagulation group showed, as we see before, gross conjunctival burns or scarring. What about the vision reduction? the laser energy reaches the posterior pole in the 3 or 5% of the case, of the laser amount energy, and it can cause macular edema. But for example, in this paper, you can see that when they used the slow coagulation technique, they found no decrease in visual acuity. The efficacy is very high, success rate of 72%, and with a mean IOP reduction of 45%. About the post-operative management, at the end of the treatment, you can use a drop of cycloplegic and a topical steroid. And about the home therapy, we use steroid drops 4 times a day for 1 week, and then 2 times a day for another week. So this technique, using the new G-probe illuminated and the slow coagulation technique with a viscous interface, you have at the end less inflammation, a targeted and precise laser treatment, and less energy dispersion that cannot cause a visual reduction. And is possible if you need to perform a trabeculectomy, if the procedure of laser is not successful, to perform, for example, in this work, they performed the phacotrabeculectomy, and the IOP of all patients was below 21 without any glaucoma medication. This is a brief video, only to show. Here there is you can see the anterior margin of the ciliary body, the area to treat, and you can mark easily this point, and so you reach your target very precisely, and then remember to avoid the marked point. In conclusion, this is a work by our clinic. We treated with the slow coagulation 40 patients with a good visual acuity, 0.7 logmar, and as you can see, we have very few amount of side effects, and we were able to withdraw the Diamox in 14 out of 16 patients. The mean IOP per treatment was 26, and in all the patients we have no visual acuity reduction. The starting was 0.7, and after 6 months is 0.7, and this is the IOP. The starting IOP was 26, and the average IOP after the treatment, after 6 months, is about 16 millimeters of mercury. Thank you.
So are there any questions on your side?
I have one question for you, Thomas. So, for example, MLT is performed in the office setting, and it is, let's say, not painful at all for the patients. I saw your cases. Is it always necessary to do the TLT in the operating room, and or you can do it also in the office? And is it painful for the patients?
So when you perform the procedure during those 2 minutes, there is actually ciliary spasm, and that can be uncomfortable for the patient. So in general, in most cases, it is actually more comfortable to have the procedure be done in the operating room. And like maybe 50% of the cases, surgeons would perform a peribulbar block prior to the procedure. In some other scenarios, when you have anesthesiologist, you can just do a deep sedation for those 2 minutes to perform the procedure. Let's say you don't have an OR available and you need to do it in your clinic, it can be performed. There's actually a Dr. Mark Totenberg who published anesthesia technique, which is just with topical anesthesia. So you have to make sure that the patient is someone who can actually tolerate some discomfort. You have to make sure that you do a proper topical anesthesia if you have to do it outside of the OR. Great. And Raffaele, you were talking about trying to avoid the marks, right? That's because the energy gets absorbed by the marks, right? So you want to make sure that...
Yes, because if the laser energy is absorbed by the marks, you can risk burn of the tissue.
And do you reserve traditional CPC mainly for refractive cases with bad vision, or you do it also a little bit earlier within the glaucoma spectrum?
No, we use also earlier, as I show, because we use also in the patient that can that have a good visual acuity after penetrating surgery, or not ever is the first treatment.
Mm-hmm. So today we're actually covering for early disease where we do more MLT, for more moderate disease where we use the Micropulse TLT, and then for more advanced disease where we do the CPC. Now Stela, do you have, when you do MLT, you said there are almost never IOP spikes and there's very little to no inflammation. What happens, do you repeat the procedure? Do you still get similar pressure reductions when you repeat the procedure over time? How much does it last in your experience?
Yeah. So we usually perform another treatment if we see that, let's say, that we did not obtain the reduction that we were expected in the IOP, and we did not see any IOP spikes or significant inflammation afterwards. So I would say that it is really a safe procedure to do.
Terrific. Since we're actually already on our time, anyone that may have a question, a last question to ask over there?
Yes, it's possible. No, after a goniotomy or not successful goniotomy or trabeculectomy, you can use this technique.
Can you ask? Just repeat the question if you want.
Yeah, okay, yeah, if we apply the pilocarpine before the treatment, yeah, we apply it. Yeah, we apply it if we see that the pupil is not, let's say, very strict. Yeah, you can apply it. But it's not the rule that you need to do it always. It's not the rule, yeah.
Great. Well, thank you very much for joining us.